Hi guys, welcome to another session. Today we're going to look at the drug Amiodarone. We're going to have a look at its presentation, its mechanism of action, some of the usages, the side effects, and some of the pharmacokinetics. If we start off with presentation, Amiodarone is a benzofuran derivative. It comes in tablet form, normally 100 to 200 milligram tablets, and it comes in a clear IV solution, which is in an ampule size of 150 milligrams. This is often diluted up with 5% dextrose for whatever infusion purposes you're using it for. It's important to note that amiodarone is an irritant and therefore shouldn't normally be given via a peripheral vein and should be given via more of a central vein. When we think about the mechanism of action of amiodarone, it is a typical class 3 antiarrhythmic on the Vaughan-Williams classification, but it does have some class 1, 2 and 4 properties also. Class 3 antiarrhythmics are potassium channel blockers. It slows down the rate of the cardiac repolarization, therefore increasing the duration of the action potential. And if you have a look at the screen now, you can see that demonstrated on the image. It also increases the refractory period, and it can also have an effect by prolonging the QTc. When we think about usages of amiodarone, typically it's used in the treatment of SVT, ventricular tachycardias, and Wolff-Parkinson-White syndrome. Most commonly, it's used in the treatment of atrial fibrillation. Classically on the ITU, we typically use it as an infusion. We start off with a 5 mg per kg over 1 hour, and then for the remaining 23 hours, we use a 15 mg per kg infusion. At 24 hours, we then alter it depending on the effects of the amiodarone. When we think about the side effects of amiodarone, if we think about the lungs, typically there is a 10% chance that you may develop pneumonitis, fibrosis, or pleuritis. If we think about the thyroid gland, there's two main types. There's amiodarone-induced thyroiditis type 1 and amiodarone-induced thyroiditis type 2. Type 1 is often associated with people who have underlying thyroid disease, and that's typically treated with anti-thyroid drugs. Type 2 is typically it's a destructive thyroiditis where you get amiodarone-induced destruction of the follicular cells, which leads to leakages of the thyroid hormone, and then leads to a transient thyroiditis. This is typically treated with steroids. If we think about the liver, there is hepatic involvement from amiodarone, and it can lead to cirrhosis, and it can also lead to hepatitis. And if we think about the skin, it can lead to essentially a photosensitive rash on the skin, and it can also lead to an ashen grey appearance on the skin also. If we think about the pharmacokinetics, amiodarone has got poor gut absorption and only has about a 50 to 70% oral bioavailability. It's a highly protein-bound drug in the plasma to about 95%, and it's got a long elimination half-life of anywhere between 20 to 100 days, and that's because of the iodine component of amiodarone. It's excreted by the lacrimal glands, by the skin, and by the biliary tree.